I'd like to introduce you to our speakers, Cindy Winters and Toby Fryer. Toby Fryer is president of New Ulm Medical Center and vice president of the West Region Community Hospitals of Allina Health. Toby has 13 years of rural healthcare executive experience, is a fellow of the American College of Healthcare Executives, and has been a frequent speaker across the nation on rural health transformation. During his time as president, New Ulm Medical Center has received the American Hospital Association NOVA Award, Minnesota Hospital Association Innovation of the Year and Community Health Improvement Award, 5-time Top 100 Critical Access Hospital Award by iVantage, and numerous recognitions for quality and patient experience. New Ulm Medical Center, a part of Allina Health, is a fully integrated rural delivery system and national leader in population health due to the Heart of New Ulm project. Within New Ulm, Toby has contributed as a leader with Rotary International, Chamber of Commerce, Park and Recreation Commission, Legacy Dads, and Grace Community Church. Cindy Winters is the manager of the Heart Beat Back, the Heart of New Ulm project in New Ulm. Her primary responsibility is to transition a 10-year demonstration research project to a community-owned and driven project beyond the initial funding period. She helps to implement and embed programs within community organizations and works with community agencies and organizations to adopt policies and systems that will sustain the behavioral changes and momentum created by the Heart of New Ulm project. Cindy works with community partners to provide education on systems, environmental and policy change strategies, and provides technical assistance on the implementation of these strategies to meet their organizational and constituents' needs. Now I'll turn it over to Cindy and Toby.
Hi, good afternoon, everyone. Again, this is Toby Fryer, and I have with me Cindy Winters. We'll be spending the next 45 minutes or so going over information related to the Heart of New Ulm project and a little bit about our broader population health model here based in New Ulm, Minnesota. I'll be kind of facilitating the first half of the session, and Cindy will take the second half with some of the more details on the program and our community engagement strategies. I would very much look forward to any feedback, questions, recommendations from the audience that's gathered today. So I'll be monitoring the chat box, or at the end, look forward to some robust dialogue and discussion. So as has been mentioned and shared already, the Heart of New Ulm project is a significant population health project for our community, really for our system, our state, and we think also for the nation, given the level of investment and the duration of this project. But really our population health model is beyond just the Heart of New Ulm project. And as I advance to the next slide here, wanted to share this because it, I think, speaks to the breadth of how we see population health, and we put this together last week for a different audience that came on site for a presentation. And it speaks to our vision for rural health of leading with innovation around healthcare access, value, and health improvement, and really based off of outcomes, that it's not just the strategies, not just the tactics, but we will know we're successful by the outcomes we have in our community, and largely around the triple aim of improved health outcomes within the care system, improved health outcomes outside the walls of this organization at the community level, and then broader and more affordability for the healthcare services and health status we so desire to achieve. And there's three buckets in the middle here. Is if you follow this local healthcare access model, we feel it's really important to develop a robust and highly integrated local care delivery model with primary care physicians and specialty care, and that feeds into our hospital and other community-based healthcare services. And then in the second bucket here, we look at care improvement through a regional system. So New Ulm Medical Center is part of Allina Health, a large regional healthcare system based in Minnesota with 12 hospitals across the state. And so what we try to do is do everything we can to leverage the expertise and the resources of Allina Health System and infuse that expertise and resource into our local healthcare model so that we can enhance the care that we can deliver locally, as well as when someone needs to leave the community, we can, in a very integrated, seamless fashion, transition that patient to a higher level of care, and then reintegrate them back into our community. And we do that through on-site specialty care, through telehealth programs, through clinical service line programs at the local level, as well as at our tertiary partner at Abbott Northwestern Hospital. And then lastly, we look at a community health engagement model as a part of this population health effort, and that's where the Heart of New Ulm rests in our community model, and has been very important. And that's really the focus of the discussion and presentation today, is this last box here with the community health engagement and Heart of New Ulm. All of these, we are trying to increase membership and market share in unique lives that we care for in the region. We're trying to do everything we can to accelerate the pace to accountable care. We're in a Medicare Pioneer ACO. We also have a network commercial plan in our community with nearly 1,000 lives in that network plan already, and some value-based arrangements with the state of Minnesota for the Medicaid population. And then, as you can see, population health improvement through the Heart of New Ulm, and all of this with a foundation of data analytics. So I wanted to share that before we get into the details of Heart of New Ulm, so hopefully there's a broader context for what population health is for our community and the model that we've created and support going forward. The Heart of New Ulm project really started as a vision from a gentleman named Dr. Kevin Graham, who was at the time president of Minneapolis Heart Institute. And Dr. Graham was a cardiologist that spent over 20 years coming to New Ulm every month to see patients, spending 2 hours each way driving here to support care and our primary care physicians in our community and our patients. And really he and his colleagues helped create a system called the Level 1 Protocol for response to myocardial infarction or heart attacks in our community and many other communities all across the state of Minnesota. And that program, and many like it across the nation over a period of time, greatly helped reduce the mortality from MIs in the community setting. And they set up a program and a goal that within 90 minutes, someone having a heart attack and presenting to our emergency department would be actually coming out of the catheterization lab at our flagship hospital, Abbott Northwestern. And as a result of that program and many others, over a period of about 3 decades, we had a 50% reduction in the MI rate across the country. But if you look at the second graph on the bottom here, this is the incident rate of MIs across the country, and you can see it's still climbing today. And that's really the issue we're trying to deal with. And Dr. Graham had a bold vision for, could we get to zero for heart attacks in one community? And we talk about innovation and what some key components of our innovation in our model. And one is to have a bold vision, and two is we have to act like there's a scarcity of resources. So that bold vision of getting to zero, I think, is really important. But why at a time where we saw 50% reduction in mortality, where we're seeing continued increasing rates of heart attacks happening across the country and in Minnesota, for that matter? A lot of it has to do with the continued concerning trends we're having with health status across the nation. So these were two maps at points in time in 1991 and in 2008 through 2010, supported by the CDC information of obesity rates by state and across the country. And I think this morning, some of us probably have seen on the news, they updated or refreshed the obesity data. And it's even worse than the picture that's on the slide here, where as a country we're at 38% of our adults are obese, and we see some variation by states, but it's pretty well consistent across all of our nation, this epidemic. And we see this as a real driver. Despite everything we've tried to throw at this health problem from the medical system, we continue to see challenges of a worsening health status. So this project was all about, could we move upstream 5 years ahead of an event happening in our ER and do whatever we could to partner with a patient, partner with a community to prevent heart attacks from happening in the first place? And that prevention would happen because we would be minimizing risk factors across an entire community level. So there's a lot of research that has been happening with this Heart of New Ulm project. Actually, probably half of our budget is dedicated to research that's happening. And the research is happening over a long period of time, 10 years, and the goal is, could we reduce the heart attack rate here in this community, this zip code of of residents more significantly than anywhere else in our peer or comparison communities. And in the moderate term, can we also improve risk factors that contribute to heart attacks and other health conditions that not only raise the cost of health care but decrease the quality of life. So we have 9 of these risk factors that are modifiable that we're monitoring across the community and doing everything we can to bring interventions to the community to try to improve each of these over the period of 10 years from 2008 through 2018. I think also something that this project is centered around is knowing that, and the studies all vary by 5 to 10%, but most of them will show that about 20% of our own health status is influenced by the medical care we receive, and about 80% is determined by social economic status, the environment we live in, genetics, and other factors. So we know that a significant portion of our health, our community health, is influenced by things that happen outside of the walls of our organization, and that's foundational to the Heart of New Ulm project and really our population health model here, and where we strive for health improvement. There was a video that we were going to embed and not able to do that today, but we'll at the end hopefully redirect everyone to the website where there's a lot of great videos that bring to life this project. It's more than data, it's more than information on slides, and hopefully everyone will have a chance to spend about 5 minutes watching some of the videos at the end of the presentation today. But innovative features of this project are, one, it's funded and managed primarily by the healthcare system. So Allina Health back in 2007 and 8 was planning for this initiative and could see into the future that population health, community health improvement would be vital not only to our organizational success but the success of every community that we partnered in. And this project was going to be funded at a significant level, almost $9 million to date by the Allina Health System, not through government grants or other programs, but primarily through the healthcare system. And it was going to be planned for a long time, 10 plus years of research and interventions at a community. Most of these types of projects or similar ones are for 2 years, 3 years. This is at 10 years plus, which gives us an advantage of being able to monitor the changes across a community from a population health perspective. And the last bullet point here I think is really, really important, and it's that our electronic health record is the primary population health surveillance tool. So in our community, we can respond to the question of what is the health status of our adolescents, the children, the adults, by demographic, by neighborhood, all across the community. We understand the health of this community, and one of the main reasons we know that is based on the health record and how we utilize it in capturing health information, what we populate in the health record. So we're not dependent on health ranking surveys, county health data that supplements our surveillance tool here for monitoring health status, but that isn't the primary tool that we utilize. And I think as more have adopted an electronic medical record across the nation, I think more and more communities will have that opportunity to share the electronic health record as the foundation to health improvement. Collecting data, utilizing data is really important, and as on the first slide I shared, for us it's more than data. Data has to become information, and information has to become strategy that is actionable in our community. But you can see here by this slide we really incorporate multiple sources to kind of feed a fully comprehensive data package that can inform that strategy, and it's community surveys, it's environmental assessments. The electronic health record is obviously important, and then we also did some independent screenings in the community as well and captured information that we maybe wouldn't typically capture during a standard clinic visit. So we were inventorying how many minutes of physical activity community members would have on a weekly basis, how many fruits and vegetables they would consume on a daily basis. And while we may get there in our future of capturing more of that information on a regular basis during health encounters, we didn't have that as a baseline, so we incorporated that from a screening standpoint over 3 different screening periods over the last 8 years. As we were capturing data within the system and using the electronic health record as the kind of monitor of health status, we had to stratify risk for the 56073 zip code. and understanding, even though we had a large budget to work with, given how much most of the dollars were allocated to research, we didn't have an endless amount of money to really do a personal intervention for every life in our community. So we had to look at who would be at low risk and benefit from environmental and policy interventions, or maybe a little bit of lifestyle, all the way to the other side of the continuum, who would be high risk and not only would need the support of a positive environment to support lifestyle, but also maybe some coaching and maybe some more intensive medical management of aspirin use or hypertensive medication, and some very aggressive medical management where we would be really working on primary and secondary prevention efforts across the community. And all of this would be based on a risk score for every patient within the community that would be filtered through our electronic health record and be able to inform providers at a local community level. When we were able to screening and the risk stratification, it confirmed that New Ulm was not selected for this study or this demonstration project because this was the easy community or the low-hanging fruit of looking for health improvement across America. This is a community that prides itself on German heritage, and there's a lot of German features, including diets, in this community that were going to be hard to change and modify. Some kind of had done a little teasing about the community of New Ulm. Well, it's known for 3 Bs, butter, bratwurst, and beer. And there's some truth to that. So when we did our first screening and updated the electronic health record, found that over 75% of the community was overweight and obese. A significant portion had metabolic syndrome, and our diet did not consist of fruits and vegetables, nor did our community have a adequate amount of physical activity. So we had health risk factors that mirrored or probably were even worse than national averages. But that was our baseline, and we were determined that's not where we were going to end. That was only going to be the starting point for our community. And within a period of about 3 to 4 years, we were able to rescreen in the community, again, look in the electronic health record and see what changes had been made based on interventions, which we'll get into here in several minutes. But we were able to see in a very short period of time, diets were changing, more fruits and vegetables were being consumed, more people were taking daily aspirin as a preventive measure, more people were getting physical activity, and some of the outcome measures of cholesterol and blood pressure, significant population shifts of 4 to 7% within a period of just 3 to 4 years across the community. And when we looked at some of our data compared to national benchmarks, we're able to see many of these changes not only were significant from a community standpoint, but in comparison to the rest of the nation, far beyond changes we were seeing in benchmark or peer communities. So for blood pressure management, we had a 6.7% improvement when the rest of the nation in our compare group for age and demographics actually worsened by 0.5%, or blood pressure medication up 9.3 compared to 1.5%, or LDL management about a 4.5% spread, or the total cholesterol at goal about 7.5% spread. So those were all positive for us. We were able to also see that we weren't moving the needle as much on obesity at a community level the first 3 or 4 years. We've since seen small improvement. We'll have some data, I think, to share in the last 3 years. But more than anything, I think we're quite satisfied with. We stabilized obesity rates, and now we've started to see a small improvement toward less obesity in our community, and seeing that as a positive, especially given the national updates that were just shared this morning, and that trend continues to worsen. We also were able to see not only how we improved in outcomes, but whether we were able to activate the population toward kind of this partnership to health. And we see that as a partnership between the healthcare provider, the community, the individual, the family unit, all across our community. And this slide will show back in 2006, before the project began, in our population zip code, we had 2,000 people that knew their LDL. Maybe they didn't know it, but we knew their LDL level for cholesterol. And about 57% of that population had an LDL of under 130. When we fast forward to 2014, this was a year that we didn't have any robust screening going on. Now we have 4,600 people in a static population of no population growth over about a period of 8 years. Now we have 4,600 people who are having LDL value, and they know it, and up to 72% that are under 130. And I really call this an activation of population, because in 2009, in order to get the spike in LDL values, we had to offer a free screening for people to come into the healthcare system to know their numbers. 2014, we didn't have to offer a free screening for 5,000 people, and we still have 4,600 people. So it tells me when people are coming into the clinic for preventive care that we're doing a better job of capturing and ordering tests that would help us monitor population health and health indicators. And now we have a greater percentage of the population that knows their numbers and knows what risk they have, and the resources and the community that can help support overall health improvement. We also have been working on smoking and smoking cessation programs and others, and you can see over a period of about 8 years on where we track everyday smokers, about a 3 to 4% drop in everyday smokers. I think all of us recognize the H sign as we go into communities, and especially in rural healthcare, how critical our rural hospitals are to our community. But we started to discuss here of how do we reframe or redefine the H in our community, because I think it's too limiting and just think of our organizations as hospitals, because people think of hospitals as where people go or the organization that is there for sick care. And we want to be more than just an organization that will help sick people become well, but we want to help other people focus on wellness and health improvement across a community and across a region. So I think our organizations will be much more about health organizations in our community in the years ahead, and that's really how we've been able trying to refocus our organization purpose and mission and strategy in our model here. And the Heart of New Ulm approach, so you got the kind of a flavor for some of the outcomes, some of the measures, and wanted to start there to kind of hopefully set the table for everyone understanding it's just not a group of cool programs here. We're really focused on outcomes and measurement and defining success and really focused on the triple aim. Now we're going to start to walk you through a little bit more of the model and the approach that was taken. And we initially set this up in 3 spheres of what could we do from an intervention and strategy development in the healthcare sphere, so within the walls of the organization and the medical practice. What could we do at the worksite level, knowing that our employers and the amount of time employees spend working is significant, and that's a great opportunity for influence on the amount of time everyone spends at their worksite, as well as the health benefits that many maintain through an employer. And then lastly, in the community at large, with community programs, but also environmental and policy work that we would do in a community setting. And we look at this project through the lens of knowing that we're going to have to work at multiple levels to try to influence and partner with people on hopefully getting to better health care and better health across a community. And we've kind of shared this mission or goal statement of, could we get to a point where health is a shared goal by all individuals, by family units, by organizations, by businesses, by our city, that it's not just the hospital that cares about the health of the community, but that it's truly embraced as a goal shared by all. And this is at the individual level. Some of our interventions may be interpersonal and programs in a certain neighborhood or situation in our community, or organizational or community, and then lastly, even more recently at the policy level within our community. And we'll dig into a little more detail as we go. And the policy and environment work, we'll start there, has been really important. I would say the Heart of New Ulm launched, and we were all about community education, bringing an awareness and improving and enhancing, elevating health literacy all across the community. Everybody should know what their health status is, kind of current state baseline, and then understanding how important that is to the future of the goals that they would have in their family, for their business, for the organization, for the community. So we did a lot of programming and then realized in order to be more sustainable, programming would be ineffective, 1, because it's more costly, and 2, that we don't reach the entire population. So we had to come back and figure out, how do we, yes, do programming and improve health education in a community, but how do we also come alongside the community and do what we can to bring interventions to redesign the community and make the community more healthier, because a healthy choice is an easier choice to make in the community because of the design and partnerships we create. So this is a slide that just says, hey, we're working on sidewalks, we're working on bike lanes, we're working on recreation facilities and walk-to-school programs and making it safer in the community. Those are as important as it is of doing a billboard campaign of trying to motivate people to get their 150 minutes of physical activity across the community. There was a video I would normally share during a presentation like this, and it's called The Fun Theory from Volkswagen, and really it talks about how influential our community design can be on the choices and behaviors of a population. And what it shows is coming out of a subway system, individuals that get off of a subway, they have two choices: walk up the stairs or walk up or stand on the escalator and ride it up the escalator. And the majority of people take the escalator. But when they redesigned the stairs to actually be piano keys, it doubled the number of the people that would actually take the stairs when he added fun into the environment. And what we've kind of challenged our community on is how could we incorporate the fun theory, and maybe it's not fun in every aspect, but maybe it's safety in other as a factor. But what are all the factors that can help people, again, have as an easier choice, the healthy choice in our community? I'm going to turn it over to Cindy Winters right now, and she's going to talk through more of the details of, in our community, the programs, the environmental redesign, how all of that has been happening, who have kind of been the facilitators, catalysts for this work, and how it's shifted from being Heart of New Ulm centric and led with a team of people to a very small team of just a couple individuals, but yet still wide impact, significant impact across the community. So, Cindy, can you take over?
Okay, yeah, thanks, Toby. So this picture, this slide is a picture of the city of New Ulm, and in October of 2013, we brought a national expert, transportation expert to the community, Mark Fenton. If you ever have the opportunity to listen to him, you really need to listen to him. He's very motivational and very educational about how your environment impacts your ability to get physical activity. And New Ulm, when I've been here since 2012, is very blessed to have really wide streets, which is also a blessing and a curse, because wide streets promote speed, which prevents people from wanting to walk or bike along beside them. And we're also very fortunate that we have sidewalks. But we needed someone from the outside to come in and look at our community and provide us with an assessment of what the barriers were for people to walk and bike in the community. People were walking and biking as a form of recreation, but they weren't doing it as a form of transportation. And to really get that tipping point for the community to become healthier overall, we needed to shift that so that people are using active transportation on a more consistent basis. So they came and did an assessment for us and created a report. And as a result of receiving that report, we put together a coalition of key decision makers in the community that had the ability to make change. So we had the city engineers, city council members, people from the hospital, people from the school systems, parks and recreation, bike and walk advocates, the police department, all sit around the table and really talk about, okay, out of these recommendations, we need to prioritize them. What can we get done? What's the lowest hanging fruit to begin with, so that we have some early successes, so we can show the community what environmental change is really all about and how it can benefit the community. And since we had this assessment and report done, there were 6 major recommendations which are listed at the top, and we prioritized them. Out of those 6, we've been able to accomplish 4 of them in a very short period of time, and we've got 6 big ones still left that we're continue to work on, and we're identifying more that we need to work on in the future as well. So the policy systems and environmental changes that we're doing right now are to really look at, we've increased the farmers market season, so we worked with the farmers market organizers to make the season longer, and we added more hours to the market. We're working on getting complete streets policy in place. That is a long process because you're working with the city and changing just the way really people think about what their city looks like, and you're also working on changing city processes, which can be really challenging at times. But we're able to post signage around the community for a 12-mile circle bike path around town, and this slide says that we have additional signage planned for 2015, and we did really start the work in 2015, and we actually found out last night that the city has approved putting down bike sharrows on some designated bike routes throughout town. So we have a circle route that goes around town, but now we also have about 165 blocks of low volume traffic streets that will be designated as bike routes, and we're going to start painting sharrows on them so that people in town know to expect to see bicyclists along those routes so that they will slow down. And we have done community resident surveys, and the residents have told us that about 30% of the residents would bike more often if they felt safer. So we hope that these sharrows are really going to help change the environment so that they feel safer, so that they'll walk and bike more places. And we now have the Safe Routes to School program that we have a very detailed plan, and we have a Minnesota Green Corps member that's working on implementing that plan. And we've got a lot of information on what the barriers that parents see to allow their kids to walk and bike to school. And I already mentioned the low traffic volume streets. We've also assessed our food environment. So we've worked with all of the restaurants, all of the convenience stores and the grocery stores, and we've gone in and done the National Nutrition Measurement Survey to identify what foods are available in all of those locations. And we brought together the restaurant owners to talk about what it is that they could make as far as changes within their restaurants to provide healthier options. We were trying to reduce the amount of beer, broths, and butter that were being consumed in New Ulm, and we wanted to replace those with non-fried vegetables. We wanted some fruit, and we wanted to see some smaller portion sizes and whole grain bread. Now, we've got about 36 restaurants in New Ulm, and right now we have 15 that are part of our recognition program, and they're recognized according to the number of changes that they make on their menu. We have some restaurants that will never be able to be a part of the recognition program just because of the type of restaurant that they are. If they provide buffets and things like that, you can't control portion size, but those organizations have changed and improved the types of oils that they prepare their foods with so that they're healthier oils. And we've seen some significant changes. That we have one restaurant in particular that sold a lot more fries, and when we suggested that they might try and do some side salads instead, she was just adamant that this was not going to happen in her restaurant. It was never going to work, but she was willing to try it, and now she sells more side salads than they do French fries, and she's also one of the biggest proponents of the program in the community. So, okay, so a lot of what we've done is, in addition to the initiatives that we've done around making changes in our community, we have a really strong communication strategy. We've really tried to infiltrate messages, consistent messages throughout the community so that people can see it, get it in their home. We have newsletters. We put ads in the paper. We work with the cable TV. They have different shows and messages on the shows. We work with the radio station in town really closely, and we also have put up billboards. We found that billboards are very cost-effective, and I think people have kind of learned our strategy because you put a billboard up and it stays up till the next person buys it. So we would pay, for a billboard thinking it'd be up for a month and it'd be up for 6 months, so we'd have some really good messaging there. We've done messaging through work sites. The healthcare clinic put up flyers and posters. We have a really robust website that has a lot of information on it, and we work through our community partners to do a lot of messaging as well, and we really concentrate on what those messages will be and really coordinate those throughout the entire community. So the Heart of New Ulm project, from the goal was to help improve the community's health, but it also served as a research project that would rigorously measure and report outcomes and develop approaches that could be successfully replicated. So it was really critical that we assess, develop, and implement and evaluate our programs and solutions and services. And then we built community capacity for the long-term maintenance of those efforts. So we've really looked at who is participating in our programs, who is participating in our leadership, and what kind of information do they need in order to be able to continue the project without the research piece of it going on. And then we've taken that information, what we've learned, and translated it and put it out into, we've have several peer-reviewed articles that have been published, and we've also provided the information back to the community. So we've used our data to develop a variety of different types of communication tools. We've created fact sheets that talk to the residents of New Ulm about what we've been doing in New Ulm and what the results of that data have been, so that they know that we have made positive changes in the community. We put out an annual report every year that every resident in the community gets or has access to. It's also posted on our website. And we've changed the format of that as well, so it's easier to read, it's quicker. It's more about the residents of New Ulm rather than the research project, but we still do a lot of the communication around the research piece as well, because that's important as well. So this next slide is just a piece of a material that we developed that tells the results of a community resident survey that we conducted in 2015. And after we did the resident survey, we brought together key stakeholders in the community and had a discussion around the results and decided we needed to know what the residents of the community valued about the Heart of New Ulm project, because we were in the 6th year of the project and we had 3 more years left. We wanted to know what the values were of the project and where we'd missed the mark and what gaps did we still need to address in those last few years. So this is just a piece of the communications that we use to share back with the community. And this is what the residents of New Ulm told us, is that the Heart of New Ulm project, after 7 years, over 90% of the residents of New Ulm know what the Heart of New Ulm project is. They may not know about every single component, but when you say Heart of New Ulm, they know what you're talking about, and they take a lot of pride in that, in the project. We also learned that 99% of the residents in New Ulm are maintaining a healthy lifestyle and that they value health as a part of their life, and they really value the program overall and don't want to see it go away after the research is done. And so as part of this the resident survey that we conducted, we were really trying to get at measuring culture change, which is really is difficult. So we asked residents, what do you think your neighbors are doing, or what have you changed over the course of the last 7 years? And a lot of them said that they are eating more fruits and vegetables, they're drinking fewer sweetened beverages, they're increasing their physical activity level, and they're losing body weight. So they're trying to lose that 5 pounds. They're not out to lose a bunch of weight, but they really are watching their weight, and they're trying to lose weight the best way possible, which was taking it slow. And the perceived residents' culture change is that people think that everyone's more physically active, and it's true. You see more people out walking and biking now than you did when I first came to town. You see the bike racks in town are getting fuller. We have more bike racks in town that promote biking. We're just really trying to make those visual cues much more apparent in the community around physical activity so that people will participate in those events. We also have some outdoor fitness equipment that we've installed in our parks outdoors, because we know that not everybody can afford to go to a recreation center or a gym. So we have outdoor fitness equipment that can be in the parks year-round, so everyone has access to it. And there's more articles and information in the newspaper about health, and that there's more healthful choices when people are cooking. More people are shopping at the farmer's market. The farmer's market sells out before it's often closing time because we've created such a demand, and the producers haven't been able to keep up with some of that demand, which is a good problem to have. And they think that fewer people are smoking and that they're choosing healthier options when they eat out. So when I came to this community in 2012, when I used to talk about community buy-in, and they're like, well, we have great buy-in. People participate in our programs, and I did a survey of all the leadership team members or the steering committee members when I came, and I asked about community buy-in and community ownership, and they really felt that the people in the community supported the program because it was something the hospital did, and they were the hospital. But in order to keep this program going beyond the research period and really to get it embedded and ingrained within the community, it really needed to become community owned. So now we talk about it more about community ownership rather than community buy-in. So we're really working to get that community ownership so that there's more agencies outside of the health department or the health system that are working on the project. So we went from a 36-member steering committee that met quarterly to a 13-member leadership team that meets monthly. And we have action teams that that work off of that leadership team. We used to have a much larger staff, and now we're down to like a 3.3 FTE staff, and there's one full-time person on the ground here in New Ulm where we used to have 4. But we don't need all those staff members because we have a very activated community that is really interested in what is it that we can do to improve the health in our community, and what is our role, and how can we help do that within our own agency. So we have teams that work on the Safe Routes to School program, and we have a team that works on the Complete Streets initiatives, and those two teams work really closely together to change the physical environment so more people are physically active. We know that we are not reaching everybody in the community, so we have a health equity action team that's working on reaching those people, which Toby's going to talk about a little bit later. And we're bringing different partners to the table that were never at the table before, and really empowering them to do more of the work. And we're really trying to identify what information it is that they need to know to help them do that work. And we have a worksite wellness action team that works on allowing worksites to network together so that they can address worksite wellness issues and barriers that have been identified as well. And so as a result of having these action teams, when we had a 36-member steering committee, we had about 22 really active members, and now we have actually more participation through our action teams than we do through the steering committee. So some of the keys to a successful partnership are to really align around a shared purpose, understand the value of health and wellness, and our leadership team in the community has created a mission statement of supporting a culture of wellness rather than health, because we had a lot of discussions about health, and a lot of the people around the table really felt that health happened in the hospital, but wellness could happen out in the community, so we're supporting a culture of wellness. Consider anchor institutions. So when we went from a much larger steering committee, we went to like a smaller leadership team, and we have 5 anchor institutions that always have a seat at the table, and that's the city, the public health, the hospital, the schools, and the Chamber of Commerce. And that could look different in any community. It just depends on where your key decision makers are, the ones that are innovative and willing to take those bold steps and can see the future and a vision for your community. And you really want to have continuity as well. So you really want to have a lot of discussions about what it is that you're working on, and why is it that you're going there, and what is it that each organization can provide to the overall project. And you have to come up with common process measures. And that's kind of a hard discussion to have at times, because we all want to measure different things, but what is it that we really need to know so that we're making progress, and what's measurable and what's not, and what types of information can we really use and put to good use and then share back to our community.
And this is Toby again. We're in the kind of final slides here, transition to close. And I know we haven't been able to get in all the details of all the programs. We could kind of break down the nutrition environment, the physical activity, many aspects of the project. There will be great resources on the website for anyone that's interested in materials. We've been very transparent with everything that's been created and would like to share and spread those to other communities. But the phase we're in right now is really thinking long and hard about after the research is concluded and after the kind of initial funding comes to an end, what's the project look like, how does it get incorporated into our sustained population health model. And as you see here at the beginning of the project, Alina Health was a primary grantor and sponsor of most of the project activities and programs to where we are in 2015. Community stakeholders begin to cost share, where we create pathways for community businesses, community organizations, other public organizations to take on some of the work that was originated by the Heart of New Ulm project. And that was great to be able to create a path towards sustainability in our community. And then as we look to the future in 2019 and beyond, we see it more of a community and healthcare partnership in the leadership and the funding of the initiatives, that this wouldn't primarily be funded any longer just by the healthcare system. We absolutely would have a role, would be the backbone organization, but we would expect community organizations to come forward again where we have health or wellness be a shared goal by all, and that other organizations would come with funding because of that shared interest, that shared goal for the community. And equally as important is health or wellness would actually show up in their strategy. So if we think about the chamber strategic plan, that we need health or wellness to show up in their plan. As we think about the schools, we need health and wellness to show up for our schools. For obviously public health it will be, but many of our other community organizations, that's where we're going. And the healthcare organization is still the catalyst, the facilitator of many of those conversations. But as you can see, we can now transition to a model where we have one full-time staff member in the community here, but is impacting 10 to 20 community leaders and organizations that then are impacting hundreds and thousands of employees and community residents based on the strategy being disseminated across the community and shared across the community. One thing that was very helpful for us is the creation of using our electronic health record and the electronic data warehouse and bringing it into geographic information system, and we're able to now analyze health status not only at a community level for our population, but we could do it by demographic, by age, by social economic status. We can also do it by neighborhood. And what we did is we loaded our registries for depression, for asthma, and diabetes, and we created clustering or hotspots across the community where chronic illness was more present. And as we were thinking about our strategies, we kind of had more of a one-size-fits-all strategy from our clinic and from the Heart of New Ulm project, and we've now revisited and said, well, no, how do we come up with new ways to engage our populations and serve their needs? So if we're trying to work on chronic illness management or preventive services like colon cancer screening, we can't just send a letter out reminding every person of this. We need to come up with new tactics. So we've partnered across the community, again, not just the healthcare system, but reached out to public health, to our Park and Rec department in the city of New Ulm, to this other nonprofit, Pro Kinship for Kids, and we're starting to create kind of these neighborhood gatherings in some of these what we would call hotspot neighborhoods in our community, engaging the population and understanding how could we come alongside and support and engage and bring not only programming and education, but hopefully services that will be helpful in health improvement at the neighborhood level and across the entire kind of social economic classes across a community, which we feel is going to be pretty important to minimize disparities. Our work sites, Cindy had mentioned a lot about what we're doing there, but our work sites are doing a great job in cost sharing and really bringing on resources to help with work And at the beginning of this project, that was mostly led and funded by Heart of New Ulm, and now that's really embraced at the community level. So I think is another great example of, as communities are thinking about sustainability and building a budget to support this work, we no longer have to think about all of this on the shoulders of the hospital in a rural community. We've kind of come up with some different success factors, and kind of this framework we feel is pretty important. And one is we started the project and felt like education was going to be very important. So we want the entire community to understand what is the health status of the community, what's the health status of each individual, and enhance that health literacy and educate people on what they can do personally to make changes in their life, and what are all the community resources within the healthcare system and at the community level and at their work sites to support them in doing that. And then we kind of transitioned to define responsibilities and roles all across the community. Again, that this is a shared initiative, shared project all across the community. And when you can enlist the City of New Ulm for support, or the school district for support, or the chamber for support, or other nonprofits, they're interested. They have health as a goal or wellness as a goal. They just needed help and guidance of understanding what they could do and where they could be responsible in the community. And then lastly, empowerment. At the end of the day, I think all of us think, well, if it's about it, then it has to be the healthcare organization that does a lot of the work. And I think this empowerment of a community, when you create a vision, when you create an educational framework and defining roles, then the empowerment can occur. And really, it's very gratifying to see an entire community activate and embrace this and take it to places that the healthcare system never could have on our own. And when we think of this from a community standpoint of what others can start with, it's knowing your community. The electronic health data is very important, understanding health indicators at a community level, so that will require data systems, data analytics to be in place to monitor this, and I think that can help tell a story. One thing we can get numb to here in our community is just looking at data sheet after data sheet and just see numbers. And just even putting that on a map and seeing that's our community really has activated a whole new group of people of wanting to do something about it, because that's our community. And if there's people struggling with their health and not connected to community resources, we want to change that. But it takes a foundation of some data analytics to help support that. And then, as Cindy had mentioned, has done a great job here, is building a coalition of key decision makers. That, again, this can't just be about the hospital and what the hospital can do, but get the right community leaders around the table and start planning those efforts and starting with maybe one opportunity and building off of it from there. What we've shared today, just at a high level, didn't happen in 1 year. It's happened over 8 years. And I think for other communities it will take time as well, but we have no regrets of the path we've taken. We've learned, we've failed, and we're trying to share as much as we can with other communities. And that, I think, wraps up the slides and the presentation that we had, and it looks like we have about 5 or 6 minutes, and would be great to hear any questions the audience would have today. Or Kim, if you have anything for follow-up.
Thank you so much, Toby and Cindy. Every time I hear this presentation, I'm just blown away by New Ulm and by your leadership, and you really are just a role model for rural hospitals and communities to work together in community partnerships. So thank you for sharing that. If anyone has any questions for Toby or Cindy today, you can unmute your line by pressing *2, or you can go ahead and type a question right into the chat box. You can also hover over my name and send me a private question if you'd like. Also, if you'd like to take some time to look at those 2 short videos that Toby and Cindy were talking about, they are in the PowerPoint presentation, the PDF that I sent to all of you, and you can just click on the links to view those. They're really inspiring short videos. All right, if there's no questions, I'm just going to thank you once more, Cindy and Toby, for speaking today. Please complete the short online assessment to receive 1 ACHE Qualified Education Credit for today's webinar. Thank you so much, everyone. Have a great afternoon.
Thank you.